Friends, this is part 3 for shoulder manual therapy, and my name is Dr. Subhash Khatri. I think in part 1 and 2 we almost spoke up to this. I call it as a scapular foundation principle. Let me see the pointer option. Okay, and this is LRST muscles, that is levator scapulae, then rhomboids, serratus anterior, and lower part of the trapezius. So remember that in order to build up the scapular foundation for the shoulder, one should not forget about working at LRST muscles, that is levator scapulae, rhomboids, serratus anterior, and lower end of the trapezius. A scapular dyskinesia, a non-specific response to glenohumeral pain, injury, or pathology put up by Ben Kibler. Ben Kibler thought that sometimes there's a scapular dyskinesia. That means scapula doesn't move the way it should move. So initially we can start thinking about training with the manual assistance, and slowly once the patient learns how to control this dyskinesia, uh, we can involve a little more active efforts from the patient for the shoulder treatment. Okay, this is an interesting concept. I call it as a MAC concept. And now MAC stands here for multiplanar, asymmetrical, and capsular. If your patient comes with the pain and stiffness, which is multiplanar, that means your patient is getting pain and stiffness in 3 planes. That is sagittal plane also, frontal plane also, and transverse plane. Your patient has got asymmetrical limitation of movements, otherwise stiffness. That means one movement is more limited than the other one. That means one movement is say 70% limited, another movement is 50% limited, third movement is just 20% limited. That kind of limitation of movement we call it as asymmetrical. And if there's a capsular pattern of limitation, so try and understand that if your patient has got this MAC, that is multiplanar, asymmetrical, and capsular pattern, that suggests that your patient has got adhesive capsulitis, otherwise frozen shoulder. Now there are 3 dysfunctions as far as rotator cuff is concerned at the shoulder. We call it as supraspinatus dysfunction, infraspinatus dysfunction, and subscapular dysfunction. When your patient has got supraspinatus dysfunction, your patient's complaint is pain, otherwise stiffness on active abduction. If your patient has got dysfunction of infraspinatus, then patient complains difficulty in reaching to the opposite scapula. But if your patient has got problem in the subscapularis, the popular sign we call it the lift off, that is, you can ask your patient to try to reach to the opposite gluteal region, or otherwise opposite backpack, and try to lift up the elbow. And if your patient finds this position difficult or inability, then probably your patient has got dysfunction in subscapularis. So supraspinatus abduction, infraspinatus reaching to opposite scapula, and subscapularis is lift off sign. Okay, change for you also, me also. When there's a pharma lecture, sedative and hypnotics, and you are giving live demo of benzodiazepines. That's a funny thing. But if it is monotonous, then it is possible that one can slip in the class. Of course, not in this way. This is an interesting concept in shoulder physiotherapy. I call it as a RE, that is active assisted exercise. Remember that our trick is very simple, that if your patient's active movement is painful, one of the best options is using active assisted exercise. So when active movement is painful, choose active assisted exercise. That can be Codman's exercises, otherwise pendular exercise, otherwise assistance by the opposite hand, otherwise assistance by a physiotherapist, otherwise assistance in form of suspension, otherwise assistance in form of a wand, stick, towel, or anything. But remember that when active movement is painful, the best option is active assisted exercise. Now this is an interesting concept. I call it a SAT concept, that is shoulder abduction test. Just ask the patient to put up the say elbow over the head like this. Um, this is going to perform shoulder abduction, and if by doing this the patient's shoulder pain is elevated, otherwise reduced, then pathology is in cervical spine. And in that case you can think about using distraction, otherwise traction, as one of the treatment. So if shoulder abduction reduces the shoulder pathology, think about working at cervical spine. Now this is an interesting concept. I call it as a suprascapular neuropathy. Sometimes the patient walks in with a shoulder complaint, and if you look at the scapular region, you see a lot of vesting, and patient doesn't give you a perfect kind of a history that could relate that your patient should have shoulder pathology. But if you go into the depth of, say, especially medical history, surgical history, sometimes what happens is patient was probably a suspected case of tuberculosis, say pulmonary tuberculosis, and because the gold standard is lymph node biopsy. Your patient goes to surgeon, say ENT surgeon, gets lymph node biopsy done, and sometimes after that, there is this kind of condition we call it as suprascapular neuropathy. Because of that, there's a weakness of supraspinatus and almost all the scapular muscles. Because of that, the patient puts the entire shoulder into adduction, internal rotation, finds it difficult to perform the active movement, but passively there's no problem. So if you come across such kind of patients, then you got to think about managing even suprascapular neuropathy in addition to just working at shoulder. So understand that maybe rare, not the regular cause, but one of unusual cause of shoulder pathology could be suprascapular neuropathy. Now the treatment concept is very simple from medical management point of view. We call it as A, B, C, D, E. Analgesic. Instead of bed rest, we can just say that rest. C is like cuff and collar. D is diazepam, that is like more of muscle relaxant, and E stands for exercise. So analgesic, rest, cuff and collar, diazepam, and exercises is the theme of treating the shoulder pathologies. When you look at the investigations, especially as a physiotherapist, I want you to appreciate this half moon sign. If you see the half moon sign, that means shoulder is pretty normal as far as subluxation and instabilities are concerned. Now look at this patient. There are two pathologies. If you can see these prominent things. So your patient has got the fracture as well as pseudoarthrosis of clavicle. Okay, here's the gem as a change for you. When I was saying I decided to go to medical school. At the entrance exam, we were asked to rearrange the letters and form the important human body part, which is most useful. Okay, and those who answered spine, they are the doctors, while the rest are on Facebook. That's a funny thing. I didn't want to read. I'm so sorry that this kind of joke had come here, but it's okay. Now, this is an interesting concept as far as biomechanics is concerned. I read this concept from the author White and Punjabi. Uh, Punjabi is Manohar Punjabi. He's probably from Chandigarh, working in US, and has contributed a lot as far as spine biomechanics is concerned. But I like this concept. I call it as a man concept, or as pan concept. Man stands for muscle, other is myofascial, articular, and neurological, other is neural. If you don't like man, call it as a pan. So passive, active, and neurological. So my submission here is very simple. It's like a triangle, and we get stuck up in this triangle, either as a physiotherapist or as a patient. We feel problem is in the muscle, we just work at the muscle. We feel problem is in the joint, we just work at the joint. But we forget the neurological things such as control system, otherwise even proprioception. So trick here is work at all the three things. That is articulation also, muscles also, and neurology, otherwise neural control, or otherwise proprioception. Now, of course, we have shoulder proprioceptive exercises that I'll speak a little later on. But what I mean here is work on active system, work on passive system, and work on neurological system. So that means just working on joint is not sufficient. Just working on muscles is not sufficient. We got to work even on neurology also. So now for shoulder proprioception exercises or proprioceptive exercises, I use the trick, I call it as a shoulder clock exercise. So initially you can just ask the patient to point as if there's a clock in front of you, and point at 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock, like this. Then you can do the same exercise with the eyes closed and ask the patient to point different positions such as 12, 3, 6, 9. Then you can have random timings with the eyes closed. You can ask the patient to close the eyes and point at 10 o'clock, 4 o'clock, 8 o'clock, then 11 o'clock, likewise. Now what happens is when the patient tries to position the index finger in different say imaginary clock positions such as 12, 2, 4, your patient has to rely on more of joint position sense. So that could be one of the way to train for even the proprioceptors at the shoulder. When we are working at say muscles, otherwise fascia, we are working on active system, and when we are working at the joint, we are working on passive system. Okay, this is one of the best way to treat the shoulder. and you can use even to do that clock exercise. Now this is about shoulder plyometrics, that is throw and catch. You can use even for the shoulder stabilization also this exercise. Now one of the best way is one should not forget to evaluate the shoulder, uh, and you can use a shoulder disability questionnaire, shoulder pain and disability index, or the shoulder rating questionnaire. It helps you to find out where you are, where was your patient few weeks back and where is your patient right now. Okay, this is another example of how to work with the shoulder. Now this is kind of instrument, we call it as a profiter standing weight shift. uh, okay, the red flags. So red flags, that means dangerous situations, otherwise contraindication. And if you look at it, I have put it in a very simple way here, like A B C D E F G H. So red flags are ankylosis of the joint, otherwise patient on anticoagulants. Your patient has got bone disease, otherwise recent fracture, otherwise recent rotator cuff tear. Your patient has got cancer. Your patient has got acute dislocation. Your patient has got a lot of effusion, which is rare, as I said. Your patient has got say fever. Your patient has got general debility and bedridden. Your patient has hypermobility. If you ask me, the single uh, best contraindication that I don't want you to forget is patient having hypermobility. If your patient has got hypermobility, do not think of mobilizing that patient, otherwise touching the patient. Now, uh, ABCDE, probably I spoke about ABCD of management. Now this I can use ABCD for uh, investigation. Now when it comes to ABCD of investigation, already we had seen the X-ray. We can look for alignment, bone density, cartilage space, otherwise joint space. You can look for deformity and you can look for erosion. So we are using ABCD two times. One is for the investigation and second one is ABCD for treatment also. Now another treatment from physiotherapy point of view that I have put up in basics of orthopedic physiotherapy is, I call it as MAMA concept. MAMA stands for modality, appliance, movements and advice. This makes my job as a physiotherapist very easy. That means I got to think about modality, I got to think about appliance, I got to think about movements, and I got to think about advice. One of the best advice is avoid overuse. Then that should be at least for 6 weeks. Avoid even weight bearing through the shoulder. That is, say, while getting up, sometimes the patient makes use of shoulders and bear the weight through, say, the upper extremity and the armrest. That can be minimized. Uh, about the appliance, if at all you think of using appliance, it can be shoulder sling. Even you can prepare the shoulder sling as a sports physiotherapist in case of acute injuries. Now about modalities, one of the simple rule that I use for modality is we can use modalities during all the three phases, such as IRR, that is inflammatory repair and remodeling phase. In inflammatory phase, you got to be a little careful. So let's look at the rule. Rule is very simple. When it is acute pathology, say after 72 hours, one of the best option is you can use cryotherapy, otherwise cryocuff, otherwise even vapor coolant spray. If it is more than 72 hours, you can think about other modalities. But my trick is check the local temperature. And I always say in a funny way that just check local temperature and say, गर्म लगा तो ठंडा लगाओ, ठंडा लगा तो गर्म लगाओ, in between current लगाओ. Now what I mean is if local temperatures increase, you can think about cryotherapy. If local temperature is normal, you can think about thermotherapy. And if your patient has got other situations such as neurological symptoms, say tingling, numbness, alter sensations, spasm and things like that, you can even think about using electrotherapeutic interventions such as my personal favorites are TENS and IFT. If it is acute pathology and severe pain, I prefer using TENS, and if it is chronic, I prefer using interferential therapy. Now this is another important concept in shoulder physiotherapy. I call it as a SMS concept. S stands for stability, M stands for mobility, and S stands for strength. So three options are there. One is mobilization, strengthening, and stabilization. Okay, this is an important concept, and this you can read it. This is an article written by J.S. Lewis, that is Jeremy Lewis, and it's a probably systematic review. No, this is another concept that is about rotator cuff tendinopathy, subacromial impingement syndrome. You can refer this from BJSN, that is British Journal of Sports Medicine. Now, what he says is very simple. That is, you have four options to work with the patient. You can work at shoulder, you can work at scapula, you can work at cervical spine, you can work at thoracic spine. In another words, or others in his words, he calls it as a humeral head procedure, scapular positioning, thoracic technique, and cervical thoracic technique. Now, probably I'm confusing you here. And in your mind, question is, so what am I supposed to do? So answer is very simple. Your first choice is work at the shoulder. Your patient is fine with the shoulder. Okay, don't think about anything else. Say you work on shoulder and it's not working. Now you think about working at the shoulder as well as scapula. Say it's not working. You tried working at the scapula, you tried working at the shoulder, it's not working. Okay, then think about working at the cervical spine. Okay, when you work at cervical spine, it's okay, fine, go ahead. Say, imagine that you tried working at the shoulder, you tried working at the scapula, you tried working at the cervical spine, it's not working. Now you think about working at the thoracic spine. Now, next question in your mind is, if I tried at all four levels and it's not working, then probably check whether that patient should be seen by you. Remember that in the beginning only we had this question. Ask yourself, is this the right patient for you? Yes, go ahead. If not, refer the patient. Don't touch the patient. So right now, as a physiotherapist, you have four options: work at the shoulder, work at the scapula, work at the cervical spine, and work at the thoracic spine. Okay, the literature suggests that the spray and stretch technique is one of the best option when it comes to acute shoulder pain. And in market, otherwise online Amazon, you can buy this biofrizz spray. Spencer techniques, because of the time I'm not in a position to show you the video, but this is one of the treatment option for you. uh, okay, the CDX methods of mobilization, manipulation, as well as deep transverse flexion, including the grade 5 mobilization, otherwise a thrust manipulation. Maybe some of the other video I'll show you all shoulder manipulation techniques, that is grade 5. Maintenance mobilization, you have options right from 1 to 4, otherwise 1 to 5 also. I'm not sure if I'm showing you 1 to 5 here, but I usually say that grade 1 and 2 is for pain, 3 and 4 is for stiffness, and grade 5 is for CM, that is chronic and minimal restriction. Now, Dawn therapy, I always feel bad about the Dawn. That is, Dawn was the first person who has actually put up the concept of movement with the mobilization, but neither he enjoyed the name, fame, or money. But I like his concept, and probably he was the first person who had put up the concept about movement with the mobilization. One of the option for treating the shoulder is you can apply the glide at the thoracic spine or the cervical spine, and ask the patient to perform the active shoulder movements. So this is one option. Another option is you can do the movement with the mobilization, what we call as a Mulligan concept. Uh, so here one of the concept is about posterior glide and asking the patient to work with the shoulder movement. Usually my own modification is, instead of standing onto the opposite side, I stand onto the same side. Maybe in another video I'll show you how to work on movement with mobilization with our modification, what I spoke about. Okay, this is a joke about your knee jerk. Okay, when you look at the entire evidence says that almost all the interventions are good as far as pain relief is concerned. All our techniques are okay. They have almost the same ability to reduce the pain. But when we look at the mobility, one of the best option to get better mobility is movement with the mobilization. And this is what is that systematic review I was mentioning, because okay, this article is by another author, and this you can see it in Journal of Manual and Manipulative Physiotherapy in 2009. Okay, this is another shock. Till that, I just drink little water. Okay, you can think about using local procedures at the shoulder, such as localized stretching the cervical spine muscles. Then you can use myofascial release kind of techniques. You can have self stretch. You can have ischemic compression technique. Otherwise, I call it as a pressure point release. You can have Maitland's mobilization. You can have grade 5 mobilization, otherwise manipulation. Uh, Another way to work at stretching at different regions. This is one of the way to do the rhythmic stabilization for shoulder. Now this has been published. So I always say that one of the hidden muscle is subscapularis. And what happens is your patient complains of pain on external rotation. Now problem is in subscapularis and we are directly mobilizing or otherwise stretching. So what you got to do is palpate the subscapularis muscle, and what you got to do is see if it is in spasm. If it is in spasm, apply the gentle pressure. If it is tight, then you can stretch it. And if you find that there's a tender spot, then you can think about using ischemic compression technique. So you have three options: so ischemic compression technique, maybe fleurage, and stretching, depending on what is the pathology at subscapularis muscle, that is spasm, tightness, otherwise just the tender spot, otherwise trigger point. So thank you so much, and this is the end of shoulder physiotherapy concepts from manual therapy point of view. And I'm Dr. Subhash Khatri. I'll be happy to listen to comments. Okay, we'll stop here.